Welcome. In today's session, we are going to look at the human breast. And by the end of this session, you should state the location, shape, and the extent of the human breast. You should also describe the structure. You should also describe its blood supply and the lymphatic drainage. And we will look something under clinical correlations. Welcome all. My name is Wallace Munyene and I'm the Ure Doctor. So, breast or the mammary gland. It is just a modified sweat gland that present in the superficial fascia of the pectoral region. Now, the mammary gland is found in both sexes, both males and females have it. However, it remains rudimentary in male, but becomes well developed in female at puberty. Now, on rare occasions, the breast of a male becomes enlarged. This condition is known as gynecomastia. In female, it is an accessory sex organ of female reproductive system and also provides milk to the newborn baby. Now, the anatomy of the breast is of great surgical importance and therefore needs to be studied in detail, okay? So, let's look at the location. The breast is located in the superficial fascia of the pectoral region. Then we have a small extension from its superolateral part. That extension is known as the axillary tail of Spence. However, it pierces the deep fascia and extends into the axilla. Okay, so the aperture in the deep fascia through which the axillary tail passes into the axilla is known as the foramen of Langer. Okay, so the axillary tail is the site of high percentage of breast tumor. So most breast tumors occur in the axillary tail of Spence. So here it is. Okay, this is just a diagram. This is the nipple and the areola. Then you can see here on its superolateral aspect, we have the axillary tail of Spence, and this aperture in the deep fascia is known as the foramen of Langer. So this axillary tail of Spence is found in the axilla. So shape and its extent. Now, the breast is hemispherical in shape. How does it extend? Vertically, it usually extends from the second to the sixth rib, and horizontally, it also extends from the lateral border of sternum to the mid-axillary line. So, despite the variations in size, the base of the breast is fairly constant, and this is the base. From second vertical extend from second to the sixth rib, horizontal extend from the lateral border of sternum to the mid-axillary line. Okay, that is the base of the breast. Okay, and the nipple usually lie in the fourth intercostal space, and this applies to non-pendulous breast. Okay, in pendulous breast, the nipple might not be lying at the fourth intercostal space. So let's continue. Breast relations. Now, the posterior relations of the breast include the pectoral fascia, pectoralis major muscle, serratus anterior muscle, the external abdominal oblique muscles. Now, between the breast and the pectoral fascia is the retromammary space, which is filled with loose areolar tissue. Now, this loose areolar tissue is the one which allows the free movement of the breast over the pectoral fascia. So this is the breast, then this is the pectoralis major muscle, then which is covered by the pectoral fascia. Now, between the pectoral fascia and the breast, you can see this is the retromammary space, which has loose areolar tissue. Now, this loose areolar tissue allows the free movement of the breast over the pectoral fascia. And surgically, this space is used by surgeons when breast enlargement surgeries. This is the space which is utilized. It is filled with, it is usually filled to make the breast look larger. we use that retromammary space. So let's continue. The breast structure. The breast consists of these structures: the skin, stroma, and the parenchyma. Now, skin is the covering of the breast and presents the following features: a nipple, which is a conical projection below the center of the breast and usually lie in at the level of the fourth intercostal space in non-pendulous breast. Okay, it usually contains smooth muscle fibers which can make the nipple stiff and erect or flatten it. It is richly innervated, and hence it is the most sensitive part of the breast to tactile stimulation and becomes erect during sexual arousal. Now, the areola, which is also what skins present in the breast, which is a circular area of pigmented skin surrounding the base of the nipple. It usually contains a large number of modified sebaceous glands, particularly at its outer margin, which usually produce an oily secretion which lubricates the nipple and areola, thus prevents them from drying and cracking. Now, the color of the areola and the nipple usually vary with the complexion of the woman, and during pregnancy, the areola becomes larger and darker. Now, the sebaceous glands in the areola are enlarged during pregnancy and usually appear as small nodular elevations called montgomery's tubercles. Okay, so let me show you that here. This is the nipple. This dark pigmented area, that is your areola. Okay, then if you look at this areola here, you can see we have elevations. These are enlarged sebaceous glands, which are the areola glands of Montgomery. Okay, so yeah, so let's look at the stroma. Now, the stroma of the breast consists of connective tissue and fat. It forms the supporting framework of the breast. Now, the connective tissue condenses to form fibrous strands, stroke septa, which are known as the suspensory ligaments of Astre Cooper. Okay, now the suspensory ligaments of Cooper are arranged in a radial fashion, such that they connect the dermis of the overlying skin to the ducts of the breast and to the pectoral fascia. Now, these ligaments of Cooper usually maintain the protuberance of the breast, but they usually atrophy due to aging, which makes the breast pendulous in old age. Now, the fat forms the most of the bulk of the breast, and variations in size of the breast is due to this fat. It is distributed all over the breast except beneath the areola and the nipple. So let's look at the diagram. Here you can see the breast lobes. This is the parenchyma. Then here you can see these ligaments of Astre Cooper. You can see they are connecting the dermis to the lobes and to the ducts, and some to the pectoral fascia. So they maintain the protuberance of the breast. Okay, now let's look at the parenchyma. Now, the parenchyma, or the glandular tissue of the breast, secrete milk to feed the newborn baby. It consists of about 15 to 20 lobes, which are arranged in a radial fashion like the spokes of a wheel. You see those spokes of a bicycle wheel, how they are arranged in a radial fashion. That is the same way in which the lobes are usually arranged, and they converge towards the nipple. Each lobe is divided into lobules consisting of a cluster of acini. Now, each lobe is drained by a lactiferous duct, which converges towards the nipple and open at the summit of the nipple. Near the termination of each duct, it usually expands to form the lactiferous sinus, which acts as a milk reservoir. So these are the lobes. Then if we take this lobe, you can see this is one lobe. You can see it is divided into lobules, and each lobule consists of a cluster of acini. Then you can see the lactiferous duct here. Near its termination, it has an expansion, the lactiferous sinus, which is a milk reservoir. Okay, now arterial supply. The breast is usually highly vascular. This and now its arterial blood is derived from the lateral thoracic artery, which can curl around the lower border of pectoralis major, or other branches may pierce the pectoralis major muscle. Also, from the internal thoracic artery or the internal mammary artery, which sends branches through the intercostal spaces beside the sternum. Okay, with the second and the third perforating branches of the internal thoracic artery are the largest. But then we have other similar but smaller perforating branches which arise from the posterior intercostal artery. Now the pectoral branch of the pectoral branch of thoracoacromial artery supplies the upper part of the breast. Also, the superior thoracic artery supplies just a small part of the breast. Now let's look at its venous drainage. These veins, axillary vein, posterior intercostal vein, and internal thoracic vein, are the main veins which drain the breast. First, the veins are not these veins, but the small veins usually converge towards the base of the nipple. Then they form an anastomotic venous circle, from where they run into superficial and deep sets. Now, the superficial set usually the superficial veins drain into the internal thoracic artery, where the deep set, the deep veins drain into the axillary vein, posterior intercostal vein, and the internal thoracic vein. Now, why should you know the venous drainage? Because breast cancer can spread to the brain. So cancer metastases to the brain can occur via the venous route. How? Via the posterior intercostal vein. Then the posterior intercostal vein usually communicate with the external vertebral venous plexus, and the external vertebral venous plexus will communicate with your internal vertebral venous plexus. Remember, these venous plexuses are valveless, so blood flow in them is bidirectional. Okay, so then the internal vertebral venous plexus can communicate with your basilar venous plexus, and your basilar venous plexus will communicate with your inferior petrosal venous, inferior petrosal sinus, and your inferior petrosal sinus, remember, is a tributary from the cavernous sinus. Once you see, cancer cell can reach the cavernous sinus, and once cancer cells are in your cavernous sinus, that is dangerous, because cavernous sinus drains some parts of the brain, such as your remember the superficial middle cerebral vein drains into your cavernous sinus, and that superficial middle cerebral vein will communicate with your superior sagittal sinus via the superior anastomotic vein of Troland, and it can also communicate with your transverse sinus via the inferior anastomotic vein of Labere. So that is dangerous. So this is why you are learning this. So to know how cancer can spread from your breast all the way to your brain, you should know that route. So then you have the lymphatic drainage. Cancer cells can either spread through venous drainage or lymphatic drainage, the lymphatic pathway. Now, this is important. About 75% of the lymph from the breast is drained into axillary nodes, 20% into internal mammary lymph nodes, and 5% into posterior intercostal lymph nodes. Now, among the axillary lymph nodes, most of the lymph drains into the anterior axillary nodes or the pectoral axillary nodes, and the remaining into posterior and apical groups. Then the lymph from anterior and posterior groups first goes to the central and the lateral groups, and then through them into the supraclavicular lymph nodes. So here is the breast. It is divided into 4 quadrants: upper medial, lower medial, lower lateral, upper lateral. So lymphatics from the upper lateral mainly drain into this group, the pectoral group, or the anterior group of axillary lymph nodes. Then, but from the axillary tail of Spence, they drain into the posterior group of lymph nodes. Okay, they drain to this. Then from the lower lateral, they drain into the posterior intercostal lymph nodes. Then from the upper medial, especially from this medial side, they drain into the internal mammary lymph nodes or the parasternal lymph nodes, and which can communicate with the lymph nodes of the other side. So the cancer can spread from one breast to the other via this route, because the internal mammary lymph nodes of one side can communicate with that of the other side. Then from the lower medial, they also drain into the subperitoneal lymph plexus. And this subperitoneal lymph plexus can communicate with your ovary. Okay. So you will see how cancer can spread from the breast to the ovary. So, clinical correlation. Breast cancer. This is a must we talk about. It is one of the most common cancers in females. It arises from the epithelial cells of the lactiferous ducts. In about 60%, it usually occurs in the upper lateral quadrant, and it commonly affects females between ages 40 to 60. How does it present? 1. Presence of a painless hard lump. 2. Breast becomes fixed and immobile due to infiltration of the suspensory ligaments of Astley Cooper. 3. Retraction of the skin due to infiltration of the suspensory ligaments of Astley Cooper. So when the skin is retracted, there will be dimpling. So if you see, can you look at this patient? You can see here, this skin is somewhat, the skin has dimples. Okay, that is a clinical. That is telling you something is wrong there. There will be also retraction of the nipple due to infiltration and fibrosis of the lactiferous ducts, and there will, the skin of the nipple will have an orange peel appearance, what is known as powder orange. Okay, so it will look like that. You see how an orange peel looks like. That is how the skin of the patient will look like if she's suffering from breast cancer. Why? Due to obstruction of the superficial lymphatics. Now, if we continue now, let me take this down. Now, the knowledge of lymphatic drainage of the breast is of great clinical importance due to high percentage of occurrence of cancer in the breast and subsequent dissemination of cancer cell, what is known as metastasis, along the lymph vessels to the regional lymph nodes. In classical operation of radical mastectomy, now when a patient has the breast is affected, how will you manage that? The whole breast is usually removed along with the axillary lymph nodes and pectoralis major and minor muscles. Okay, why remove pectoralis major and minor muscles? Because we have a group of lymph nodes, the interpectoral lymph nodes of Rota. They are between those two muscles, and they also drain the breast. So you must remove them. So as you remove them, you also remove the muscles. Okay. So some lymph vessels from the inferomedial quadrant of the breast, remember the one I had shown you, which drain into the subperitoneal lymph plexus, communicate with the subperitoneal lymph plexus and carry cancer cells to it. From here, cancer cells usually migrate transcoelomically and deposit on the ovary, okay, producing a secondary tumor in the ovary known as the Krakenberg tumor. Okay, that is how even cancer can spread from your breast to your ovary. Now, the cancer of the breast is serious and often fatal in women, and it is common. Now, the mammography and the regular self-examination of the breast help in early detection of breast cancer and effective treatment. In mammography, usually inject the patient with a special dye, then we look for any carcinoma. Can you look? In this case, the patient was injected with a special dye. Then here you can see a lump. That is a carcinoma. Okay. Now let's look how you will carry out the regular self-examination of the breast. And this is important. It can help you a lot. Here we are. Now the steps, there are 6 steps of breast self-examination. The first step, first you stand in front of a long mirror and inspect both breasts for any discharge from the nipples. So we also look at for puckering and dimpling of the skin. Now look for any change in shape or contour of the breast. This is the first step. Okay. Then the second step, clasp your hands behind your head and press your hands forward forwards like that. Then the third step, press hands firmly on your hips and bow slightly forward as shown here. All this you are doing to see if there will be any dimpling in on the skin. Then the fourth step, during shower, raise one arm and use the finger of the other to palpate the breast in a circular fashion from periphery to nipple for any unusual lump or mass under the skin, as shown here. And you do for both. Don't just do for one, do for both. Then gently squeeze the nipple and look for any discharge, shown here, gently. Then repeat this step 4 and 5. Okay, but when repeating 4, you want to be lying down. Repeat steps 4 and 5 while lying down, and thus make it easier to palpate. So this doesn't have necessary to be during showering, can be after. So after doing this while showering, you can lie down and now repeat what you had done and this step. Okay, and by that, by doing that, you have carried out the regular and should be regular self-examination, which it can help in early detection of breast cancer, and this will lead to effective treatment. Okay, you are looking for any dimpling, for any discharge, for any change in the contour of the breast, and also you can also look for if the skin has an orange peel appearance, the pau, the orange. So, and thank you for your attention. We have come to the end of that session, and please subscribe for more anatomy and biochemistry content. Thank you.